to say what further information would be needed or what further changes, if happened, we would consider a re-referral. But the aim of the referral is to answer a specific diagnostic question. It's not, unfortunately, to say my child's not right, what could be going on. It needs the specific asking of a question that we can answer through detailed testing. So the most common referrals that we get are ASD, or autism spectrum disorder, ADHD or variations, so attention deficit and hyperactivity disorder. And then the third one is developmental coordination disorder, or DCD. The other name for that historically was dyspraxia, but we've moved away from that. So just to talk about ASD in a little bit more detail, we are starting to embrace the term of neurodiverse. And it includes historical terms such as Asperger's. We have got many luminaries, and I put a couple of examples down, such as Anthony Hopkins, the famous actor, and the founder of Pokemon, Hishori Satoshi. And as just examples of people who have limitations in social communication and their social interaction, limitations with their imagination and flexibility of thought, which can present huge difficulties for the people who are talking to them. They may be very interested in repetitive interests or restricted activities and really unkeen on engaging in activities that might be thought to be more mainstream. That is their area of passion. And their behaviours may be quite restricted or repetitive, such as issues with eating, recurrent movements, which may be stereotyped, or hand flapping that you can sometimes see in younger children. And they may have unusual sensory responses. So they may be very bothered by labels on their clothes. They may be bothered about touching certain things or seeing foods that are, for example, touching. And in the referral, what we would try and do is try and glean from the referral evidence of difficulties in a number of areas. So we would try and look and see how that child interacts, how that child communicates, particularly in school, but in other environments as well as at home. And we try and look, has this been a continued pattern? Has this been a little one who's had difficulties with language delay or their stereotyped movements that has, as their speech has improved, shown particular focus or patterns in certain areas? Can they be quite clumsy as well? And then as they move into the adolescent years, you know, we all remember how difficult the teenage years were to negotiate in school, a sort of invisible rule book that nobody seemed to tell you what the rules were. But these children have particular difficulty in making friends. You know, they may have played alongside other children when they were younger, or have children who were quite flexible to play alongside their particular desires. But that becomes a bit more difficult when you're a teenager and you don't want necessarily to stand out. And some children can find themselves quite isolated. And part of the referral pathway is the ask really of parents undertaking a behavioural management course. The obvious example for those children where we worry about ASD is the Incredible Years programme. This is because it's not just about a label that gets given at the end of the diagnostic process. It's more about helping parents and the team around the child to better look after that child once they either have a label or they don't, but they may show tendencies that would benefit from the behavioural management. And it's not because parents are not good at being parents. They know how to be parents, but there are usually some really good information that they can get from this course, you know, tips or tricks that may help them resolve certain difficult situations. And the vast majority of children and parents find that when they've come through it, it's more of a beneficial experience, as well as the diagnostic assessment. So the other parts are, and can be quite complex in unpicking, is are there any other factors that might lead to a child behaving in the way they do? There are children who can have significant attachment issues or mental health concerns that can manifest in the early stages, or could there be overlapping issues of neurodiversity as well? Things like anxiety, depression, obsessive compulsive disorder, or conduct disorder, and as teenagers are developing, gender identity disorder, gender identity issues that they're wanting to express, or, for example, areas of selective mutism or panic disorder. Some children where their mental health difficulties are the large part of their presentation may benefit from CAMHS referral. And CAMHS do have the ability to assess for ASD and ADHD within their team without necessarily having to reach for a referral to the community paediatric team. The other thing is, are there any other associated significant social care concerns? Are the child's behaviour leading to significant risk to either the child, the parents, other children in the family, or to other children in the classroom? Sometimes our referrals get escalated, and because we are at this moment a team that are trying to understand the child best, it is a lengthy assessment process, and the weight is significant. There isn't, unfortunately, the capacity to escalate children in terms of urgency, because you'd end up having to cancel another child's appointment to see somebody who was urgently presenting. And it may well be that extra help for the family as they go through the pathway, for example, with early help through social care, might well help make the child safe, actually take the heat out of the situation, and mean that the assessment can take place without the added significant pressures that can come with it. And then the other thing to consider is, are there any significant learning issues for the child? And it may be that an educational psychologist that and an assessment can be obtained through school, may just be what's needed to clarify the child's individual educational needs and recommend adjustments, and it wouldn't necessarily need a whole look at to assess for ASD. So what actually happens during the process? The initial step is assessment by the community paediatrician. Once the referral has been triaged and accepted, they get a booked appointment with the community paediatrician. And we get in lots of information from parents and school. We undertake a physical examination and clinical observation, because we want to make sure that there's nothing else going on. Is there anything that hasn't been picked up through the referral form? We need to start from the beginning, but with the basis of that significant amount of information that we need. We ask the opinion of the speech therapist, which is provided by a separate trust, so Dorset Health University Foundation Trust, and that does lead to some delays if there is a significant speech therapy waiting list. I say that just to highlight this for parents coming into the system. And we also ask the opinion of either clinical psychologists or the educational psychologist to help when it comes to making recommendations, so we can see how best to help the child in school. And if there are particular issues, such as sensory issues, whilst we can't individually address them, if our occupational therapist may be able to provide some advice if there are some targeted things that we need to do. And this is combined into an individualized report, and then you get robust conclusions and recommendations, because we know that this is a label that will last for a long time. So this has to be something that's fit for purpose for the future. If the question has been identified, it may be that the child doesn't need ongoing follow-up. For ASD, there isn't a medical treatment. 2 tablets of this will help it. I know many parents wish that there was, but at the moment there isn't that therapeutic dimension, and it's more about helping the child to function in the environment that they're in. If a diagnosis is given, the pediatrician will normally see for a further time in 6 months to see how the recommendations are bedding in. And it's really important in that appointment to focus on what are the adjustments that have been made by school and parents. Is a educational health and care plan needed in EHCP to support the child onwards? Is there anything specific we can add in the mix from occupational therapy, speech therapy and psychology at that point? And then we will make a plan individualized to the child from there. So now we're moving on to ADHD, or attention deficit and hyperactivity disorder. And as you can see from the sort of mind map there, it highlights some of the particular symptoms that children may present with. But the biggest is the hyperactivity, the inattention. Some children who just have significantly shorter attention span but don't have the hyperactivity issue may be diagnosed with just ADD, but generally it's all of those things, and it is out of character with the other children that they're with. So we know that younger children generally have a shorter attention span, but it's when it's causing significant problems, for example with learning, for example with safety and making good decisions that would normally be expected of their age, that we're interested in seeing. And I've highlighted a couple of celebrities there in terms of Justin Timberlake, Simone Biles, the Olympic gymnast, and Michael Phelps, the swimmer, to say that it is no barrier to success. I highlight this as we all know children can be really busy. They want to pack everything into their day. Does it mean they've got ADHD when they flip from activity to activity? It's about, in our assessment, we look in detail as to, does the child have capacity to concentrate when they're doing things that they want to do? Not what parents want them to do. That's an entirely different subject, but when they're doing what they want to do. And what we do is we ask for evidence of impulsivity, inattention, distractibility, and hyperactivity that occurs in more than one setting. So generally, both home and school, and if there are other settings the child is in, for example, clubs and things like that, that it's evident before the age of 12. Again, we do see the benefit in parents having taken a management course such as the PPP course, because again, as with the ASD diagnosis, we know that we want to provide an overall package of care, and parents and also teachers around the child adjusting their attitude and expectations can be immensely beneficial to the child and take a huge amount of frustration out of the situation. And it's also very helpful if the child is near but not quite at the threshold for making the diagnosis. Again, during the diagnostic process, we do think early about, are there any other factors that we need to think about? We touched earlier on attachment issues or mental health concerns. The other thing is social care concerns or the risk to the child, and the significant learning issues. And again, the support of our colleagues in CAMS, the support of our social care colleagues in terms of early help, and the support of an educational psychologist can be really useful in helping the child get the help they need early on. So what happens? So again, a child is seen by a community paediatrician. Again, the information is sourced, and we do scoring scales to see how a child benchmarks against the expected at that age. And the scoring is completed by both family and by school. And we look for this again to be present in more than one setting, and we ask for information from additional clinicians when appropriate. And this is again combined into an individualized report. We know our families really appreciate that tailored response to their own child's needs. And it may be that behavioral interventions, thinking about how to help organizational skills, adapted support with their peers can be key to making changes to how the child enjoys both education and home. And we have significant resources that we can help to support families. Those most severely affected, we do have medications to help this condition. It can take time to find the right medication. We wish that, children would come with a label of, we need guanfacine or we need atomoxetine, but they don't. And it can be quite frustrating. And we'd ask parents to bear with us whilst we get the right medication for their child and balance out what are the benefits of medication versus any potential side effects, such as weight loss or appetite changes. And we undertake 6 monthly medication reviews to make sure that the child is safe and supported. And this is both this and the ASD pathway is underpinned by national guidance to help this. The last condition perhaps to chat about that we see is developmental coordination disorder. These are children who are significantly clumsy and their coordinated motor skills, both the gross motor, so if they're running around, parents describe them as tripping over a blade of grass, or the fine motor skills, how are they doing with their handwriting, how are they doing with tying their shoelaces, we generally see problems in both those areas. It has a huge impact on activities of daily living, how effectively they can join in school, and playtime, leisure, and hobbies that they want to undertake. And we ask for support from our physios and occupational therapists for recommendations to help them function. We do look at, we do consider dyslexia, which is a problem with reading and with letters, or dyscalculia, which is a problem with numbers and maths. But these are generally better assessed by an educational psychologist with recommendations made for education because it is so specific to education. However, if a child is losing skills, so they previously had good handwriting and this is going downhill, they're slurring their speech when it was previously fine, or they're falling over when they were previously fine, this is different. This is not clumsy, this is not dyspraxia, and we want to see the child in a different pathway in case they have a different cause for this. So here's our physiotherapist in action, and this is the mainstay of DCD assessment with our occupational therapists. Our community paediatricians can be involved if needed, speech therapists can be involved if needed, and again, an individualized report putting the child at the center of recommendations is key, and generally follow-up is not required. So this is to highlight some of the things that we don't see in community pediatrics. Possible seizures, that's an acute problem. We need to see that and investigate that. That could be epilepsy, and we need to see that in the main hospital. Generalized or specific learning difficulties, which is an educational assessment with an educational psychologist. And ID CAMS, our intellectual disabilities within CAMS, will see children if their IQ is below the 3rd centile, particularly if they're having associated issues such as challenging behavior or mental health issues. Significant anxiety, emotional and mental health difficulties would definitely be within the remit of CAMS. Children who are above 16 would also go to CAMS, and children who do not have a Dorset GP, the GP would refer to their local service. So if a child is on the borders and they live in Dorset but they have a Hampshire GP, the Hampshire GP would refer to the local service in Hampshire. Sensory processing disorder, we unfortunately aren't commissioned for that at the moment. It is something we are looking at, and unfortunately, we don't have the current resources to assess for this. Similarly, sleep issues or auditory processing issues we can't do at the moment, an area of future work. We do ask for those patients who are having conduct disorder and oppositional defiant disorder, so difficulties understanding either school or parental requests to do certain activities, that would go via CAMS. So what do we need? Our ask is that the more information we get, we know that the process can seem laborious, but the more information we get, hopefully you can see from this, the more it helps the clinician and it more it helps the children going into the pathway, but also helps the recommendations coming out. I would try not to see this as hoops to jump through, but a genuine, you know, if you put the right thing in, it's like a sausage machine. If you put the right materials in, you'll get great results out the other end. Understanding what we do saves our families time, as other agencies can be best at seeing children, and we just want to avoid children crossing too much. As you can see from the pathway, there is a certain amount of crossing between trusts and services, and we want to limit that as much as possible so that children don't get lost. We're not doing this talk or managing the referral pathway to improve waiting times, but it's to give all our families that better experience, and it's not a battle with winners or losers. If the child is displaying risky behaviour, we would reiterate the support of social care or CAMS is key. So what are we doing? We are getting now more information to our SENCOs so that they know what things that we need. So we've been chatting to our SENCOs, we've provided a toolkit, and we're getting better quality referrals. We are screening the referrals quicker. Back in the height of COVID, that was almost 4 to 5 months, and it's now down to 1 or 2 weeks because our staff have been working really hard at it. They know how important it is for families to get the outpatient appointment quicker or the decision made quicker. And we're providing more information for families, both after diagnosis and the next steps. We've got 2 new consultants who have joined and an additional psychologist. And we have outsourced some of our ASD referrals again, because we were conscious that the wait is significant. We know our wait is about 9 to 12 months at the moment, and there are some delays with speech therapy and educational psychology, and that's whether school refer or we refer. There isn't a faster system if we refer. And the wait then for an appointment can be that 9 to 12 months wait. The assessment is 9 to 12 months, so it isn't fast, but the aim is to get the right decision made at the end of the day, and actually to take account of how the child changes over time, and also with the implementation of how did the parents workshop go, how did the early intervention from educational psychology go, is that making a significant difference to the child? And then the last page we'd say is some resources that we found useful. We hope that this talk is useful as well, and gives parents a clear understanding of how the process works. I'll just leave that as a few seconds just for that, for families to take in those websites there. And I'm really grateful for everybody's time. I'm also really grateful for the support of Laura Royce in helping putting together this talk, for Nicole Guppy in her help putting together the talk, and our psychologist, Christina Turner. And I would welcome any questions. Just before then, I didn't know, Laura, is there anything else, any gaping holes that I missed in that you wanted to add in at this stage?
So I think that was really, really thorough. Thank you very much for presenting it for everybody.
Thank you. So we'd welcome any questions. Yes.
Thank you very much. Brilliant talk.
Thanks,
really appreciate it. Thank you. I've got lots of really good questions here, so I'll just do them one at a time if I may.
Yes.
And then obviously throw questions from the floor as well, please. But first one's coming. Are girls now being diagnosed sooner? Historically, their symptoms weren't spotted as quickly.
Yes, so thank you very much. I think that was an aspect of the talk that we were looking at in preparing it. We know that the symptoms for girls can be, particularly for ASD, can be much more subtle. Girls are much better at hiding these things. Boys they just hang it out there, frankly, and so it can be easier to spot. So we are picking up girls earlier. We know as a tendency, we probably the ratio is about 9 boys for every girl diagnosed with ASD, but we have lowered our threshold to look, and yeah, it's part of our longer term understanding of the neurological the neurobehavioral changes that are present with autism, and we'll see how this evolves. But yes, girls are being diagnosed earlier because we're looking for it a bit harder.
Fantastic, thank you. Another question here. Have you seen an increase in cases off the back of the pandemic?
Yes, I think so. I think the two things that probably have, there was a little bit in the early stages of the pandemic where the number of referrals slightly dipped just because teachers and SENCOs weren't having as much contact with the children. So it was slightly harder to gain the information that we needed. So we're seeing a slight spike from that point of view. I think there's a lot out there in terms of neurodiversity, and many families are wondering earlier if, we do know even from very early stages that children with autism can have subtle differences that their parents can pick up on. But we are also encouraging our SENCOs to refer. We do want to see those children where we can make a genuine difference with their education. And so if it is having a material impact on education, we are getting those referrals through. I was chatting a little bit in the audience with a member of the audience about, it's not just those children who are creating trouble in school that we want to see. It is those children who are struggling, but they may be struggling quietly.
A question on the back of that that's come through. Do you offer support guidance to schools with supporting the children and raising awareness with their classmates? And a bit of a follow on from that one, actually, if I may group two together. And for families, how can you explain a diagnosis to my child's sibling? So again, it's sort of a bit connected with that.
Absolutely. I think so to take things in turn, in terms of schools, we are providing more post-diagnosis information for schools, as well as the individualized program, the individualized recommendations that come with every child's diagnosis. Our psychologist Christina Turner has worked really hard to try and make more general information available to schools to help them. As regards to siblings, I think that can be reasonably individual depending on the age and the understanding of the sibling. It may be that some of that work can be undertaken by SENCOs, so that the child, the sibling, if they're at the same school, can have, or even at a different school, if it's fed through to the SENCO, it becomes less of a disruption to the child, because if a sibling has to be brought into hospital to tell them, they're automatically thinking it's a much bigger deal. Whereas if the SENCOs have enough information on the sibling, know the sibling well, they can have a quiet conversation about how the diagnosis can impact, if you see what I mean, above the information that we normally provide and all of the resources that are out there at the moment.
And here's a very interesting one. Is ADHD hereditary? I'm pregnant and finding confusing messages online.
Okay, it's not hereditary, so there isn't a specific gene that we would test for that gets passed down. There are tendencies that come through the family, if you see what I mean. So and the problem is that, like I say, it can be difficult to interpret in a very young child because their attention span is pretty short anyway. But we do see some tendencies that go within families, and that can help because the families already know how to support, particularly grandparents that have looked after, their child who may have had attention issues, may then be in a better place to to look after subsequent children, if you see what I mean. So there's greater understanding and a greater awareness and earlier referrals. So tendency, but nothing more.
Fantastic, thank you. And I got one more question from online, but then if there's anyone in the room, obviously, please do. This one is, are there any seasonal peaks in the presentation of children with these conditions, summer versus winter? Really interesting question.
That is really interesting. I think it would be fair to say that these conditions are, you know, that they're manifesting through the year, through the life of the child. So seeing seasonal variations in presentations is not common. I think our referrals come in reasonably constantly through the year. I think the only fluctuations that we see are when Senkos are on holiday, if you see what I mean. So we do, you know, that those natural troughs when, and sometimes it can be one event that tips a presentation over, if you see what I mean. One specific event where, you know, parents may have had general worries about their child, and then something happens and they go, this isn't right. Obviously, if that event affects, you know, other people in the school or nationally, as the pandemic happened, then it can trigger a more general rise in referrals. But otherwise they're reasonably constant through the year.
And just to say to anyone watching online, we will and we can post these links in the chat bar online.
Yes, please.
But also, if anyone wants them, they can email us at communications@uhd.nhs.uk, and we can email them to them as well, because I realise they'd be quite hard to type in quickly.
Yes.
So
yes.
Are there any questions from the floor? Yeah, we have a question here.
Thank you. You mentioned that medication is sometimes used for severe behaviour.
Yes.
I'm just wondering if there's any research into the long-term impact of taking medication in those circumstances.
Yes, there is. I think there's some good research in children that these medications are safe when given for the right reasons. The vast majority of these medications are given to help children access education. So once they are beyond 18, once they are in, you know, and you know, obviously the medications can roll on when the children are in university, but once they're in their chosen career, many adults function perfectly well without the medications, because there isn't quite the strain on them to concentrate, and come off the medications and long term do really very well. I think the number of adults who are on long-term medication for ADD is tiny and a little bit out of my experience to comment on, but there's no long-term adverse effect from taking it in childhood and then rolling on to adulthood. Thank you.
Thank you so much.
Thank you. Thoroughly enjoyed the talk. It was really, really interesting. I was just wondering, for youngsters who have a diagnosis of a neurodiverse condition, one of the typical things is being very socially inept and struggling in social situations. Within Dorset, is there any provision of professional social skills coaching? Because that seems like something that would be extremely valuable, but I'm not aware that it exists.
I think it would be a great augmentation to the provision that they currently have. Unfortunately, it's not within the core provision of the NHS, if you see what I mean, because that often is a how can they engage better in school, and we would wonder whether that could be provided, you know, better in an educational setting rather than having to come to hospital. You know, in terms of the practicalities, it may be more easy to set that up. The other thing is looking to have a supportive coach, you know, that can be sourced. Obviously, within the current cost of living crisis, it may be really difficult for families to access that kind of resource without it costing, unfortunately, and availability. Yeah, but often it's the right person as much as anything else. If you do find the right person that can help you with those techniques, and it doesn't necessarily need to be a single professional, many peers, who, undertake, they look after friends or family, or, know things through other routes, and often give that time voluntarily to help a vulnerable child who's struggling. That would perhaps be a way of organising it, though it would probably be a bit more informal rather than formalised.
Yes, I'd just like to say that we would, in a child who's been diagnosed with the autism spectrum condition, we would, as one of our recommendations back to school following diagnosis, be recommending regular and repeated input from the ELSA service, so emotional literacy service, which schools provide. Often some of these children have already been having that input on a regular basis, but post-diagnosis we would be recommending that continues, and that is also reviewed, so that strategies are put in place, time given for them to embed, and then that they're seen again and reviewed throughout their school career. So as the child is developing, becoming older, coming into different situations that are challenging for them, they're getting tailored and specific emotional literacy support around that. So that would be specific within school following a diagnosis of autism spectrum disorder. I can't speak to what's available for adults, unfortunately, because that's outside my remit.
Thanks so much, Laura.
One more question.
Of course.
Okay. How do you differentiate between ADHD and a difficult hyperactive child?
So that is part of, I mean, that's a really key question. That comes to the core of what we do, and that's why I showed that really busy slide earlier on of what a child likes to do. I think are they difficult when they're doing things that they want to do would be a key question. Are they, for example, unable to game because of their difficulties? Are they, is their attention so short that they can't do gaming or watch online on YouTube? And the problem is all of those things are tuned in to really quick, moving sequences where children can rapidly flick from one thing to the next. But are you noticing somebody whose attention span is so short they can't even engage in that? Would be something of interest. I do also try and work out what's happening is the same thing happening in lots of different environments, or is the child, sometimes very difficult in the home environment and very good in school, which can often be difficult and hyperactive, or are they difficult in school and absolutely fine at home? Would be a useful thing. The other thing is are there things that can contribute? Is the child hungry? Is the child, have they had sufficient exercise and things like that? Many children, particularly because of the cost of living crisis, are going to school hungry, and some of their behaviours are being a little bit more unmasked because of that. There are a few extra things, and I think you need to know the child individually to comment more, but just a few things that might help the thinking.
Fantastic, thank you for that. And I think an amazing time to end on a Calvin and Hobbes slide. But just to say, really, really entertaining, but also very informative talk. So thank you very much for your time, for coming across and for doing that. Well, and as I say, we'll share the links, but really appreciate it. Thank you very much indeed.
Grateful for the team for setting all of this kit up and making it happen.